Standard obesity management for patients with or without type 2 diabetes currently centers on a weekly 2.4 milligram maintenance dose of subcutaneous semaglutide. This curve illustrates the outcomes of that standard dose. While the average response is significant, the red tail on the left identifies the efficacy ceiling, a group of patients who do not reach their therapeutic weight loss goals on 2.4 milligrams. For these individuals, standard maintenance dosing appears to saturate GLP-1 receptors, or reach a plateau before achieving the deep weight loss often seen with bariatric surgery. This leads researchers to a direct physiological test. What occurs when the maintenance dose is tripled to 7.2 milligrams? Clinical trials must now determine if this increased incretin exposure produces further weight reduction or if it primarily results in higher systemic toxicity. The STEP-UP Phase 3b trials were established to evaluate the safety and efficacy of this 7.2 milligram escalation. The trial design incorporates 1,047 non-diabetic patients and 512 with type 2 diabetes. Both cohorts were randomized 3-1-1 to 7.2 milligrams, 2.4 milligrams, and placebo. Titration is rapid. At week 20, participants jump directly from 2.4 to the 7.2 milligram dose, bypassing intermediate steps. This design tests the predictive accuracy of Phase 3a pharmacokinetic models, which suggested that gastrointestinal side effects would reach a plateau even at these higher exposure levels. Primary efficacy is measured at the 72-week endpoint, using a treatment policy estimand to reflect outcomes regardless of dose reductions or treatment adherence. In the type 2 diabetes cohort, the placebo group reached a weight reduction of 3.9%. The standard 2.4 milligram dose achieved a 10.4% reduction, but the 7.2 milligram dose extended this further, reaching 13.2%. When looking at the non-diabetic cohort, the drug's performance increases without the resistance of background diabetic metabolic factors. The 7.2 milligram dose resulted in an 18.7% reduction in total body weight. This creates an estimated treatment difference of 3.1% between the high dose and the 2.4 milligram standard in the non-diabetic population. Beyond the averages, categorical data shows how many patients reached specific significant weight loss thresholds. This bar chart compares the percentage of patients achieving substantial reductions of more than 20% and more than 25% of their body mass. In the non-diabetic cohort, nearly a third of patients on the 7.2 milligram dose achieved a reduction of 25% or greater. They were twice as likely to reach these deep weight loss categories compared to the 2.4 milligram group. Tripling the dose allows a significant proportion of patients to reach weight loss levels previously associated with bariatric intervention. In addition to weight loss, the trial evaluated underlying glucose control and systemic metabolic health. Type 2 diabetes is characterized by metabolic inertia, a physiological resistance to weight loss often driven by high insulin levels and background medications. The 7.2 milligram dose overcomes a portion of this inertia, producing an estimated treatment difference in HbA1c reductions between 1.5 and 2. This data table tracks severe hypoglycemic episodes. For both the 2.4 and 7.2 milligram doses, the incidence of level 3 severe episodes was 0. This safety profile validates the glucose-dependent mechanism of semaglutide. Even at receptor saturation, the drug does not drive blood sugar below safe levels. The 7.2 milligram dose achieves superior glycemic control and addresses metabolic inertia without increasing the risk of severe hypoglycemia. We must also examine the toxicity profile to see if tripling the dose results in a proportional increase in adverse events. Gastrointestinal disorders are the most common side effects of the GLP-1 class and typically serve as the primary factor limiting patient tolerance. In the diabetic cohort, the gastrointestinal event rate for 7.2 milligrams was 53.1%, nearly identical to the 2.4 milligram dose. This confirms earlier models. Gastrointestinal events plateau at higher exposures rather than increasing linearly. While gastrointestinal events remained frequent, the higher dose revealed a new emerging neurological signal. Patients on the higher dose reported an increase in dysesthesia, a condition involving altered or unusual sensations on the skin. The data shows a spike in dysesthesia cases occurring at week 20, the exact point patients escalated to the 7.2 milligram dose. This onset appears directly tied to the sudden increase in systemic exposure. This curve differs from the gastrointestinal profile, which typically peaks early during titration and then remains stable. In the diabetic cohort, 18.9% of high-dose patients reported these sensations, while the non-diabetic cohort saw an incidence of 22.9%. These rates significantly exceed the 5 to 6% incidence in standard groups, pointing to a dose-driven effect. However, most dysesthesia events were mild to moderate in severity and didn't require stopping the medication. Permanent discontinuation due to skin sensations occurred in less than 1% of the high-dose group. Clinical management of the 7.2 milligram dose requires monitoring these sensory signals alongside established gastrointestinal protocols. Evaluating the overall utility of the 7.2 milligram dose requires weighing the clinical gains against the reported side effects. This matrix outlines the trade-offs. The left side shows clear efficacy gains, more patients achieving 20% weight loss and deeper HbA1c control. The right side shows the costs, specifically increased dysesthesia. Yet permanent discontinuation, severe hypoglycemia, and fatal events remained statistically rare. These findings suggest that high-dose GLP-1 escalation is a viable and safe strategy for weight management. These trial results provide a data-driven foundation for future updates to obesity treatment algorithms. The 7.2 milligram dose represents a potential non-surgical pathway for patients who do not reach their clinical goals on standard maintenance therapy. This is particularly relevant for patients with type 2 diabetes, who often require more intensive therapy to overcome metabolic resistance. For clinicians, the trial marks a shift in monitoring, adding sensory neurological checks to the standard management of gastrointestinal health. Tripling the dose does not destabilize the metabolic system. Instead, it establishes a new upper limit for what can be achieved with non-invasive weight management.